Today we'll be talking about what I feel is the ultimate hormone replacement therapy. This modality that we're talking about today is the only form of hormone delivery that allows the body to control the release of the hormone and effect what is most important, and that is a physiologic change within the individual patient. This is not just a symptom reliever. All the other forms of hormone replacement have unfortunately been utilized thinking that symptom relief is the ultimate goal, when the true ultimate goal of hormone replacement therapy should be to effect a physiologic change that will bring that patient's internal physiology back to the point where they were when they were much younger, premenopausal for women and preandropausal for men. The history of hormone pellet implants basically dates back to the 30s, and at that point in time they were being utilized in not only the United States but in Australia as well as Europe. They were found to be superior to other forms of hormone delivery because they allow the body to have a consistent, continual release of hormone, and releasing that hormone at physiologic levels. In other words, replicating the levels that the human body once was capable of producing. In fact, Greenblatt, in his published paper of 1949, found that the implantation of hard compressed pellets of crystalline steroids resulted in a slow and more physiologic absorption of that hormone, and that the amount of hormone released to the organism is continuous, although it be minute in quantity. It basically replicated the physiologic action of the hormone that it was being utilized to replace. So what makes up the ultimate hormone replacement therapy? Number one, we want it to be biologically identical. In other words, we'd like for it to conform to the parameters that would include a complete definition of biologically identical, and we'll touch on that very shortly. Secondly, we would like for it to be biologically available. What does that mean? That means being there when the organism or the human body needs it. So it does you no good to have a tremendous amount of hormone at a time when you don't need that much hormone. So being there when it's needed and at the right dose is critical. We want it to be absorbed directly, because when you're using something orally or you're using something that has to be processed in the liver, we are using a type of hormone delivery that is foreign to the human system. So we want it to be absorbed directly so that there is no usage of the first pass metabolism in the liver, which would encourage clotting factor production. Of course, it has to be effective. We want it to be effective. We want it to produce those consistent serum levels that are so desperately needed by the human body to become physiologically normal. Safety goes without question, that we want the safety factor to be there and to be sufficient enough in order for the patient to be comfortable that the usage of this would be completely safe for their well-being. We need for it to be hassle-free. Compliance is an issue. If in fact you ask patients to utilize something more than once or twice a day, they're going to be challenged to be able to be compliant, and so we want it to be as hassle-free as possible. The ultimate hormone replacement therapy then would be the pellets, because they reproduce the three essential things a normal functional endocrine organ needs to do to keep that human body normal. And that is, first of all, continuous production of the hormone, continuous secretion of the hormone, and continuous release of that hormone. No other form of therapy allows the body to release hormone continuously, because number two, the internal control and secretion of pellets is controlled by heart rate and cardiac output. So if you think of the body being a young child and the pellet being a lollipop, as the heart pumps blood across that pellet, basically what happens is that child licks that lollipop. So when you're in an exercise class, that child may be licking furiously on that lollipop to be able to release the amount of hormone that is demanded by that level of physical stress. So we need that internal control of secretion and release, which is absent in all other forms of hormone replacement. Because when you take a pill, put on a cream, use a gel, get an injection, your body no longer has the capability of controlling that substance. Whereas with the pellets, your heart rate and how much blood the heart is pumping per contraction controls the release of this and controls secretion, and basically gives you the availability to have number 3, which is the release of the right amount of hormone to maintain normal physiology at the correct time, so that the human body's demands at that particular time are met. So that is why when we talk about pellets being the ultimate hormone replacement, we talk about it because of the fact that they are able to replicate the ability for those pellets to replicate what a normal functioning endocrine organ does. So the definition of bioidentical. This cartoon basically represents what exactly the opposite of what we were talking about. We have been taught to give horse estrogen to humans. Well, if it in reverse, it would never happen, because horses make 17 different estrogens, 14 of which are estrone, whereas the human female only makes 3. The human male only makes 1. So why in God's creation would we want to be giving the human female horse hormone? So what makes the parameter biologically identical? What's that definition? First of all, we want the hormone to be biologically identical in structure. So if the human body, say, would make a hormone that's shaped like your left hand, well, you would want to receive something that is identical in structure to that. And more than that is that the human body creates hormones in certain ratios. And basically, in females, the safest ratio of estrogens is estradiol to estrone of 2:1, because that replicates the safest time in a menstrual cycle, which is the post-ovulatory luteal phase. At that point in time, a woman is at her protected best because there is an anticipation by the human body of implantation of an embryo. Likewise, in men, the testosterone to estradiol ratio, which we'll discuss much later in this lecture course, has to be a ratio of where the estradiol to estrone ratio is less than 2%. So how do we affect this? Well, first of all, we have to be able to individualize the dose to achieve physiologic normality. And if your delivery system is incapable of doing that, or you're not capable of doing that, you're really not getting a biologically identical replacement for that patient. And lastly, you need a biologically identical delivery system. And the delivery system for pellets, being that it is controlled by heart rate and cardiac output, basically answers the call for being a biologically identical delivery system. Topical creams and gels you can't control. Pills you certainly cannot control. Injections are uncontrollable. They basically control the human body, and so therefore you're not truly using a biologically identical delivery system. The slide that demonstrates how hormones are basically created in the human body, we always start with cholesterol. And then the human body extracts the 4 rings of carbon that it needs to make hormone, and then it puts it through enzymatic reactions that ultimately result in testosterone and estradiol production. In this slide, you'll also see that there's DHEA and progesterone and pregnenolone. These are substances that are precursors to making testosterone and estradiol. And yes, progesterone is vital to for the human uterus to be protected. But it also, in the first 2 weeks of the human female's menstrual cycle is basically converted to testosterone and estradiol. And so therefore the usage of that has to be understood that it could potentially potentiate testosterone and estradiol production. And likewise, more importantly, is that when testosterone and estradiol are being administered and you continue to use precursors such as DHEA, it would be like filling a glass of water and just, even though it's full, you continue to pour in water, and what happens? It overflows and it moves to other directions, which basically is what happens in the human body. The DHEA can be converted into 16-alpha hydroxyestrone or dihydrotestosterone, both of which have adverse impact on the human physiology. 16-alpha hydroxyestrone in males and females is carcinogenic to breast and prostate. Dihydrotestosterone can turn a normal prostate cell into an abnormal one. In females, dihydrotestosterone causes hair loss, as it does in excessive amounts it does in men, as well as, unfortunately, causing hair implantation and growth on the torso and trunk. So, utilizing those precursors makes no common sense if you are already using testosterone and estradiol. And remember, because of that, if you can picture that overflow, example that I gave you with a glass of water, the more DHEA you press into the system, the more at risk that patient becomes. The natural estrogens, as I said, are composed of 4 carbon rings. This slide doesn't give you a complete picture of what this estrone on the left is, because the top ring where you see the oxygen radical is really a double bond, a full double bond. Estradiol does not contain that double bond. Estriol, which is a breakdown product of estrone, basically those 2 hydroxy groups on that, on the ring on the furthest on the right, basically can be easily converted to the oxygen radical and form into estrone. So estriol is not breast protective in excess amounts, which is basically what we do when we give Biest and Triest. In excess amounts, it will be converted to estrone, and you get breast stimulation with it, and you don't get true physiologic action, because estriol, given it its normal physiologic production, has no physiologic properties whatsoever in the human body. It's estradiol in the proper ratio that protects the breast and protects the heart and protects the bone and brain. The synthetic compounds, ethinyl estradiol has that extra ethyl group at the top right ring. Equilin, which is the strongest estrone in conjugated estrogen, Premarin and Senestin and the like, has, look how many double bonds. In that second ring there is a double bond. The more double bonds you have, the stronger the breast stimulation. And the most bizarre molecule, diethylstilbestrol, which has high estrogenic index, has so many double bonds, which it fully explains why it affected such abnormal changes in the offspring of women who were given this drug to protect them from miscarrying. In this slide, the different routes of estrogen delivery, on the far left you'll see that basically the physiologic menstrual cycle, the levels of estradiol to estrone, that ratio, starting with ovulation and going through the luteal phase up until menstruation, is 2-to-1. And once again, that is the safest period of time that the human female has. And if you look under the oral, it's a 1-to-2, and that's conjugated estrogen. So conjugated estrogen reverses that ratio. As I told you, conjugated estrogen has 14 estrones in it, and those estrones dominate, the breast receptors. In patches, even at the strongest level of patch release, you still only get about a 1-to-1 ratio. Whereas with implants, you get that 2-to-1 ratio with the same dosage that you would with the highest dose of patches. So this slide fully demonstrates that you're recreating luteal phase estradiol levels as well as luteal phase ratio. Margaret Thom, in her study of 1981, wanted to see how fast this ratio was created, and found that it happened rather quickly, even within the first week. And studies that we'll see in just a moment will demonstrate that change happens even in the first 12 hours. So now, talking about that, we transitions us basically to talking about bioavailability. Bioavailability means having the right amount at the right time. And as you can see in Smith and Studd's study, they looked at pills and patches and implants, and basically over a four-day period of time showed that the oral forms, much like the topical, basically give you this roller coaster effect, whereas the patches give you what I call the kiddie coaster. Estradiol patches of a three-day type give you 60% of the estrogen in the first 18 to 24 hours, and then the body is only given 40% of that estrogen for the last couple of days. Implants over a 4-day period of time after insertion give you a steady release of that estradiol, and basically that is what you need to control physiologic and normality, and create that physiologic normality is dependent on having physiologic levels, having the right amount at the right time. Cravioto showed that estradiol to estrone ratio was created in the first 12 hours and that it lasted for almost 6 months. So therefore we can see that that we are basically creating a safe environment for that female, for her breast, her cardiovascular system, for her musculoskeletal, bony skeleton, as well as cerebrally. So that leads us to the effectiveness of this. How effective is this? Well, to be truly, to be truly apprised of how effective this is, you have to know what to look for and what to measure, because the effectiveness of hormone replacement therapy has been traditionally judged by how much I've reduced your symptoms. That isn't sufficient. We want to know how much have I changed your physiology. And in females, that effectiveness is measured by looking at the FSH, because this is a pituitary hormone that can only be measured in blood. It cannot be measured in saliva because it is a peptide hormone. So therefore, you have to use blood. You cannot use saliva to really assess whether or not you've made a physiologic change. In males, pituitary hormone is not as helpful, so total testosterone and free testosterone in males is the key to basically measuring and seeing if you've made a physiologic change. So when you talk about FSH, or a follicle stimulating hormone, this pituitary hormone tells you whether or not you've returned that physiology to a more normal state. And Margaret Thom in her study basically used a number of groups checking for all different levels of estradiol. And when you look at the second slide, you see all of her groups affected a reduction in FSH, certainly by the end of the first month, because it returned. Your goal, as it was her goal, was to return the FSH to a premenopausal level, because then and only then do you have physiologic normality recreated. Cravioto also looked at the FSH reduction and found that in the first 12 hours that there was, in his study group, there was a 20% reduction. So those patients that come in that have mid-range FSH elevation, say to 50 and 60, they may notice a change by the evening after they've been implanted in the morning. And that FSH reduction, as you see in the top graph, shows that this reduction can last up to 6 months. Because when you use physiologic doses of estradiol, and they are there continuously, you get FSH reduction. And you will find that when you start looking at blood work, that the patients who come in on creams and pills and whatever may not have any reduction of the FSH to any significant degree, and that's what's driving them to come to your office. Panay basically wanted to look at FSH level and their suppression by looking at 2 different doses. And what he really taught us is that if you use higher doses of estradiol, you get a spike at about 4 weeks, and that spike can generate a troublesome phenomenon, and it's called tachyphylaxis. Tachyphylaxis. Tachyphylaxis develops when you give excessive amounts of estradiol, and these precipitate spikes. And when the problem is not when it spikes, but on the other side of the spike, when you get that descent, even though the levels are extremely good, the patient becomes symptomatic and will call you and tell you that they have all their symptoms returning: hot flashes, night sweats, irritability, swelling, and they say, I need more hormone. And the uneducated or the poorly trained will then call them in, not do blood work, give them more hormone, and worsen the problem. We see this continuously in our practice, that people go to other folks doing pellets and come to us with estradiol levels above 400. One lady, I think, took us almost 18 months before we could give her any estrogen because of the fact she came in with a estradiol level of over 1,000. And that was because she got 3 insertions within a 6-month period of time of 50 milligrams of estradiol. You cannot use the same dose on individuals. You have to individualize the dose, and you have to make it physiologic. And that's the beauty of the dosing formula that you're going to be learning later on in this, in this course. So therefore, Panay basically wanted to show us what the levels were, but what he showed us was how tachyphylaxis develops. So let's look at beneficial effects. The beneficial effects basically, first of all, you recreate that 2-to-1 ratio of estradiol to estrone to make the human female be able to protect herself as far as her breast tissue, her brain, her cardiovascular system, and her bony skeleton. Susan Davis, who's from an Australian who is now at Monash University and has produced a number of papers on testosterone and pellet therapy, and basically, in this study showed that she used women and studied them for 2 years. One group she gave estradiol only, the other group she gave estradiol and testosterone. So the yellow line represents the folks that are on estradiol and testosterone who basically had higher fat mass, and that was the criteria she used. She wanted to see if testosterone would affect fat mass, but also see if it would have any adverse impact on lipid parameters, as we see so often with synthetic testosterone. So, in her study, she looked at baseline, lipid levels, and also looked at, the fat mass, which we'll see in a second. But after 12 weeks, there was some slight lowering of the cholesterol and triglycerides, and the HDL remained basically unchanged. At 6 months, though, there was a further reduction, although it wasn't statistically significant. You can then rest assured that the usage of pellets basically induces lowering of those lipid parameters, and the HDL, although it looks lower, is actually still proportional to what it was at 12 weeks, after insertion. The real beauty is in that third line on this second slide, where fat mass is divided by fat-free mass, which is muscle. And as you can see, under estradiol plus testosterone, in that third value down on the right, there was a statistically significant reduction in the amount of fat mass divided by muscle mass. That basically shows you that when you use testosterone, that you're going to be able to effect a reduction in that fat mass that has been basically deposited by the elevation of insulin resistance, which is so much associated with low testosterone levels. Montgomery wanted to see if it affected, the serotonin levels in the brain, and he used perimenopausal depression as his, parameter. And basically what he did was treated women with pellets and also used placebos. And the treated group showed a marked reduction in their depression. And the reason for that is that estradiol is the only estrogen that penetrates the blood-brain barrier. Estriol and estrone do not. So to affect changes, in the serotonin levels, you need to utilize estradiol. And this slide represents that beautifully. Cravioto in the study basically looked at symptomatic change and found that within the first 8 weeks there was a significant change in symptomatology, going from lack of sexual interest all the way through anxiety and somatic symptoms, and that even at 4 months after the initial insertion, even though the symptoms were starting to be recreated, they were still much better than they were at baseline. And at 6 months, the same phenomenon. The patients were feeling more of their symptoms returning, but yet never as bad as they were before, and you're going to hear that from your patients as well. John Studd, who is actually the Queen Elizabeth's gynecologist, demonstrated in his article in 1990 that pellets have a marked impact on bone density growth. And using oral estrogen and patch estradiol as comparisons, found that pellet therapy utilizing estradiol pellets raised bone density 8.3% per year. Anthony Bazan, a physician I trained who was in the Department of Integrative Medicine at Jefferson Medical College, brilliant internist and gerontologist, has a group of 60 women in which he's using estradiol and testosterone pellets, and has found that he's now getting a 10% per year growth. And we see that in our patient population as well. So John Studd's study has been well validated by what we have seen. A number of studies on including Christensen and Lindsay and Stevenson and Studd, when you compile all of their values, you can see that the oral forms, the patch, are nowhere close to the implants as far as generating bone density in the vertebral column and in the femoral neck. And as you can see, the controls studied over there throughout those studies all continued to lose bone in both areas. This slide basically demonstrates some of the potential problems with oral estrogen therapy, whether it be biologically identical or not. If it traverses the liver, it may very well induce first-pass metabolism problems such as increasing clotting factors, and the synthetics like such as the synthetic estradiols and all may very well have impact on the internal lining of the arteries, the intimal lining, where there might be disruption of that normal intimal lining, which they have shown in a number of their studies. The last one that I saw was by a Dr. Claude Dalle, D-A-L-L-E. And Dr. Dalle basically set forth the new guidelines for estrogen replacement therapy in Europe, and stated that basically that oral methods of hormone delivery should no longer be utilized because of their danger. So, using subcutaneous pellets, are they perfect? As with any other modality, there may be inherent problems. First of all, it's an active form of delivery. You have to insert it under the skin, so that gives you the potential of having bruising or maybe some bleeding, or possibly an infection, which all three are excessive bleeding and infection are very rare in our practice. Bruising is usually seen, it's usually slight and easily managed. In males, there is an increased chance of expelling those pellets if you don't limit their activity. And you have to limit males' activities for 7 days. Females, only about 3 days, because they get less pellets and they are much smaller. Also in females, there is a potential, for discovering any undiagnosed uterine problems such as fibroids or polyps, because when you're raising the estradiol levels up to the luteal phase levels, you may very well create a fibroid that may enlarge, or it may start bleeding, or a polyp may get extra blood supply that would then generate bleeding. If nothing else, you're basically exposing an undiagnosed problem, which then can be managed by the patient's physician. Susan Davis, in menopause in the year 2000, basically showed that estrogen replacement with pellets has been effective, has effects on body fat, in postmenopausal women that are associated with improved lipid parameters. What does that mean? That means she found that it decreased total cholesterol and LDL, it increased the HDL, and decreased triglycerides. And she found that using the testosterone pellets did not impact those very positive results in any negative way. In fact is that in subsequent studies we now know that testosterone stimulates the liver cell to produce its enzyme called lipoprotein lipase. Lipoprotein lipase is what basically attacks the LDL in the liver and eradicates it from the bloodstream. And so therefore, we would basically think that the usage of the testosterone that we use in pellet therapy has nothing but positive effects on lipid parameters. Safety, we always must consider, if we're going to talk about an ultimate hormone replacement therapy, it has to be safe. And so we want to look at studies that basically demonstrate that. Smith and Studd back in 1993 found that pellets did not increase thrombotic activity, that they reduce cardiovascular risk, especially compared to oral therapy, which is what the Europeans have now basically stated, that you shouldn't use oral therapy, and that it did not, in their study, did not increase the risk of breast cancer incidence. And we'll see other studies that basically state this as well. Farish, in his look at women who had surgical menopause, wanted to see if these hormone implants had adverse impact on lipoproteins, and what he found was that the LDL decreased with implants. Remember that those implants stimulate the liver to produce that lipoprotein lipase. HDL increased, especially the active fractions, the HDL2 and 3, which is so important for arterial protection. And these result in the implants not causing any profound changes in lipoproteins that you see associated with oral hormone therapy, which basically elevates the bad cholesterol and may have an adverse impact on HDL. Stanzik wanted to see if there was a difference between patches and pellets, and what he found is that the pellets produce more reproducible estrogen levels faster and remain steadier longer than patches, which is very important. If you think about it, we want physiologic levels that are consistent and continual and long-lasting so that we can recreate normal physiology. Secondly, he found, and most importantly, is that the HDL in pellet patients increased at 12 weeks, where it took 6 months for the patches to respond and create that. Morris Notilovitz, who was at the time that he wrote this article, the head of the osteoporosis program at the University of Florida, found that the usage of estradiol pellets in surgically menopausal patients demonstrated a marked increase in bone density, that there was no adverse impact on coagulation or fibrinolysis, that the HDL and triglycerides remain unaltered in his study, but that the total cholesterol decreased. In addition, carbohydrate and insulin metabolism was unaffected, as was systolic and diastolic blood pressure. So we're seeing a creation in this 2-year study of a very normal physiology. And basically the bottom line was 17-beta estradiol pellets can effectively maintain bone mineral content in surgically menopausal women without inducing adverse cardiovascular side effects. Extremely important, and a number of studies subsequent to that have demonstrated the same thing. Natragen and Gambrell, University of Georgia Medical College, their menopausal clinic, through that school, basically they've done a ton of research on pellet therapy, and they found that estrogen replacement therapy delivered by pellets does not increase either the recurrence of breast cancer or mortality rates. I myself, when I looked at this study, also was most impressed with the testosterone-only arm, because the testosterone-only arm actually showed that there was a decreased recurrence rate in breast cancer and a decreased mortality in those breast cancer survivors receiving testosterone pellets only. And in our practice, we really utilize testosterone pellets only. There are some rare individuals who basically sign waivers clearing us of any liability because they want estradiol. They either come in on it, but they want a better choice, or their quality of life is so poor that they would, as they state, I would rather die of breast cancer than to live one more day like this. And in those scenarios, we will utilize, estradiol. And so therefore, if you have a patient like that, in the dosing formula, there will be a variable that you can activate that will give you then the appropriate dose for that patient that will be, at the safest level for a breast cancer survivor. Davilar, in his study, he studied 261 women, and somebody might say, well, that's a small sample. But he studied them for 20 years. So after 20 years, what he found is that there was no increased incidence of breast cancer over individuals using no hormones whatsoever. And he found that there were less cancers overall than the control group who are on no estrogen replacement therapy. So therefore, this gives you another tool that shows breast health can be maintained. And what we found in our study is that basically we have an incidence of breast cancer in our practice that's around 1 in 750. And remember, the usual ratio of breast cancer and the rate of incidence is 1 in 9 in women who are basically on no hormone whatsoever. So there is a marked impact that may even be termed protective. But once again, I caution you, in breast cancer survivors, use testosterone pellets first. In Smith and Studd's study, published in 1993, he looked at different disease processes and then compared pills, patches, and pellets. And the pills he used were conjugated estrogen. And what he found is that oral therapy, because it uses first-pass metabolism in the liver, increases clotting factors. And the clotting studies are then altered, which would then basically not protect the cardiovascular system and actually then potentially raise the incidence of heart attack and stroke. Whereas when you're using other forms of hormone delivery, such as pills and patches, that does not occur. So when we're talking about, let's return to hormone implants and breast cancer, testosterone delivered by pellet implant does not increase the risk of breast cancer, unlike the oral synthetic methyl testosterone. Synthetic methyl testosterone actually promotes the development of the changes that could lead to dysplastic tissue in the breast, whereas 17-beta testosterone, which is what the human body makes, has a protective effect. It's anti-inflammatory and it's anti-proliferative. In other words, it suppresses glandular proliferation. So therefore, these implants show less stimulation to breast tissue and lower rates of breast cancer. And that treatment with testosterone and estradiol implants does not increase the risk of breast cancer, even in breast cancer survivors, as seen in Gambrell's study published in 2006. So, and in Dimitriakakis' study, even high doses of estrogen and progestin therapy given orally, when given with testosterone implants, did not increase breast cancer incidence. In my study, which was published, the abstract was published in Maturitas, one arm of the study was looking at breast cancer. The other two arms were ovarian cancer and endometrial adenocarcinoma. As you can see, the incidence after 10 years in our study group was 1 in 976. The incidence of breast cancer in our 20,000 patient population is now about 1 in 750. And none of those tumors have been discovered after 5 years of usage. All of these have been early tumors, like in the first 1 to 2 years. And as you know, breast cancer takes 6 years to develop. And I'll stand by a ratio of 1 in 750 at any time. So you can look at this study, and in the endometrial adenocarcinoma, we've only had one case of endometrial adenocarcinoma in that 10-year period of time. And up to date, since 1992, we have had, up to the present, there have been no cases of ovarian cancer in our patient population. So we're talking now well over 20 years. And why is that? Is because pellets suppress FSH. FSH stimulates the ovary, and it's my belief that excessive stimulation with FSH is really the underlying problem in ovarian cancer. So what are the advantages of pellet therapy? It keeps the estradiol to estrone ratio at 2 to 1, which is extremely protective for breast, bone, brain, and cardiovascular system. It produces that steady state of hormones. There is no roller coaster effect. It's hassle-free. There's minimal weight gain, if any. When you use testosterone, you're going to thicken the muscle. So they may get a couple of pounds of gain, but it's in the muscle and not in the fat. It's the best method, without a doubt, to increase bone density, far better than biphosphonates, which have really terrific problems with creation of spontaneous fractures and loss of mandibular bone. And there's no evidence that it increases the chance of breast cancer, which is extremely important because it does not stimulate breast tissue. And when you add estradiol and testosterone in combination, you do not get breast stimulation, you get breast protection. It gives you continuous secretion and release of the estradiol and testosterone in women. And in men, it gives you that same continuous release, because testosterone has to be released continuously in men for them to get the advantages, as do women, of muscle growth, bone growth, cardiovascular protection, and cerebral well-being. The internal secretion is controlled by heart rate and cardiac output. There is no internal control in any other delivery method for hormones. And that the release and secretion allows the right amount of hormone to be released at the right time, which produces that physiologic normality and not just symptom relief. So, what further benefits do we derive? First of all, testosterone delivered by implants bypass the liver. They don't affect clotting factors, especially important in men, and they don't increase the risk of thrombosis. Biologically identical testosterone, which is 17-beta testosterone, delivered by pellets, is cardiac protective, as seen by studies done by Seed, Sands, and Warboys. And it does not negate the beneficial effects of estradiol on cardiac and lipid profiles. This slide, basically, for those of you who have never seen pellets, basically demonstrates what pellets look like. That smiley face that's created in the palm is unintentional.